This is a test recording to see if the sound is working. I'm Barbara Boucher. Hello. My discussion arises from a paper in the BMJ Public Health Nutrition Journal that came out recently suggesting that vitamin D was irrelevant to the risk of COVID-19 in Britons of European ancestry. This paper reported, using the data on nearly 500,000 middle-aged Britons right across the UK, having identified 17 variants by a genome-wide association study that affected their serum 25-hydroxy-D values, though not greatly, that there was no reduction in risk of getting COVID-19 or in its severity, using recognised scores for this, using Mendelian randomisation analysis to examine the data and compare that data for subjects who were originally deficient with those who were reasonably replete. So the first thing is, why should vitamin D adequacy be protective against COVID-19? Well, it should. Vitamin D promotes innate immune responses that increase the production of defensins and catalycidin. It regulates and controls overactivity of acquired immune responses. This includes upregulating anti-inflammatory and downregulating pro-inflammatory secretion of cytokines, such as IL-10, which is increased, and IL-6, which is reduced, reducing the risk of cytokine storms. Furthermore, it upregulates local lung ACE2 receptor expression, which is known to be protective against acute respiratory distress syndrome. Furthermore, deficiency is common. 20 to 80% of different groups of North American and European men and women are deficient. A third of the American population is deficient by their definition of less than 50 nanomoles per litre, as are more than 70% of non-Hispanic black people and 40% of Hispanic people. In Britain, 40 to 60% are deficient all year round by our definition, which is the lowest in the world, of less than 25 nanomoles per litre. In Australia, 30% are deficient. In India, 40 to 66% are deficient amongst adults, but many communities have deficiency rates of 80 or even 90%. However, compare that with Africans living near the equator and traditional lifestyles whose mean 25D is 115 nanomoles per litre. Furthermore, the percentage of the population with intakes below government recommendations per day are greater than 90% in very many European countries, including the UK, 70% in North America, and it's more than 50% even in many North American countries. So advice on daily intake rates are not very helpful. People obviously don't achieve them. So is there evidence that vitamin D adequacy is protective for respiratory tract infections? Well, supplementation has been shown to reduce the rates of upper respiratory tract infections, as well as of acute asthma admissions and exacerbations of chronic pulmonary disease. And this is achieved with modest daily intakes, but you don't achieve it if you give large interval doses. And it's only been followed for up to about a year, and the reductions are up to about a third. And these are in repeated meta-analyses now done in up to 43 other previously done trials. Cross-sectionally, there's very strong inverse correlation of D status with COVID severity and mortality. But serum 25D is well known to fall in severe illness, and therefore this has been dismissed as reverse confounding. Prospectively, however, and this is evidence that often proves later to matter and be significant, includes two large studies. The first was in America, looking at nearly 200,000 people who'd become SAR test positive, and showing that the positivity rate halved with vitamin D levels, that's 25-hydroxy-D used to measure status, of 55 nanomolar, about 150 nanomoles per litre, versus deficient. This is roughly a 50% reduction in risk in those people who got COVID. And those blood levels were not baseline 10 years ago, they were within the year before the pandemic. Interestingly, when the data is stratified here by north versus south states in America, you can see the rates are much higher in northern latitudes where deficiency is more common. And in addition, as you might expect with deficiency, the rates are higher in black people than white, and in Hispanic people they're somewhere in between. Ma et al., looking again at the UK Biobank Study data, found risk ratios of 0.66, that's a 34% reduction for COVID-19 in those people who are on record as using regular supplements of vitamin D3. But there was no risk reduction with any other supplement used. In addition, more NHS, that's National Health Service staff of BAME origin in the UK got COVID than did white NHS workers. Indeed, the Lancet report just out is quite worrying. It looked at COVID mortality in 17 million Britons, adults. In the first wave, there was a much higher mortality in BAME Britons, up to 5 times as high in Black and South Asian men. In the second wave, the mortality had become equal in Black and white men, but had risen in South Asians, particularly in men. And it's interesting just to note in passing that a philanthropist had actually sent vitamin D free to all Black NHS workers. That's not a negligible number of people. In treating COVID-19, vitamin D3 is unhelpful in modest doses, so even larger doses have been given. For example, 200,000 units in a Brazilian study, but not given till 3 weeks after onset of illness. Too late to be effective, too slow to rise, to increase 25D levels. In India, 60,000 units a day orally did clear the virus in 3 times as many people after 3 weeks than had cleared amongst controls. So such results are really to be expected because the rise in 25-hydroxy-D normally takes weeks, not days. And of course it's even slower and to even lower values in severe illness because there's a marked reduction in the hepatic 25-hydroxylase activity, and therefore you just don't make it from intact D. Plus, large bolus doses, even in healthy people, cause downregulation similarly of the hepatic 25-hydroxylation process and upregulate catabolism of vitamin D and its active metabolites. This, of course, helps to reduce the risk of vitamin D overload with excessive calciferol formation. What's more, these effects are not short-lived. They last the 3 months that's been investigated and may, of course, last longer. Treatment with 25-hydroxy-D should be more effective. That's calciferol. Why? Because there are no self-regulatory effects in the tissues. The 2 enzymes I mentioned are not affected. It is rapidly absorbed and produces stable increases in serum 25D within 24 hours when given orally in its slow-release gel. And this 25D in the circulation is, of course, the substrate that supplies target tissues directly, allowing increased calciferol formation in situ with its local autocrine and paracrine effects. So, are there trials of calciferol usage? Well, there's one peer-reviewed public pilot study from Cordoba that's been published with a marked fall in rates of admission to ITU and a very marked fall in mortality. This came out late last year, but it is, of course, a smallish study. So in Barcelona, they've done a much bigger study, and that was done recently and submitted to the Lancet. The preprint looked suggestive, but it's been withdrawn, presumably for revision, because it's not, in fact, a randomised controlled trial, but a cluster trial study with only 8 clusters, which is really rather too few, and these being the wards, and there being not yet any reported proof that the people going to these wards were randomised. So that's the review of that paper is awaited. So it would be nice to think that Mendelian randomisation analyses would help here. Now, the genome-wide studies estimates genetic variant effects on serum 25-hydroxy-D, and they're used as a surrogate for lifelong D status. But there are some problems. Free 25D may be more important to target tissues than total 25D. Furthermore, the variance of the assays used even now can average 5 to 10% or even more, while the genetic variance seen in 25D averages 5 to 10%. So it can be more, but not often, and it is, of course, much less for free 25-hydroxy-D. So the genetic variants can't really compete with the problems imposed by the assays themselves. There are other problems. For example, the values seen in large population data sets vary widely from severe deficiency to the highest holiday in the sunshine values. And the rises in 25D that you get in the blood levels with either oral dosing increases or exposure to sunshine are not linear. They're S-shaped. Therefore, in deficiency here, however good your intake, it takes a lot before you can get up onto the steep part of the curve that puts the blood levels up. And once you're replete, giving more doesn't raise it further. Remember, I've said there are major effects that regulate your 25D. It cannot normally get too high. Furthermore, similar S-shaped curves are seen for the effects of vitamin D on all sorts of biological systems. Therefore, even with higher blood levels, unless you raise them from deficiency onto a decent level, you won't get an effect. And if you're replete, you're not going to see much biological effect. Furthermore, the thresholds of 25D that you need for different effects also vary. For example, it's generally accepted that 50 nanomoles per litre is pretty good for bone health. But to reduce abnormal insulin resistance, you need to get to 80 nanomoles per litre. And if you can get to over 100 nanomoles per litre during a trial of supplementation, as recently shown in reanalysis of D2D trial data, you will reduce the risk of type 2 diabetes, and very largely too in people with pre-diabetes. Now note that these increases from 25D, here it's 100%, here it's 320%, here it's 400%. Now, GWAS findings for gene variants used in MRAs are clearly too small, therefore, to induce any such health effects. And I don't know of the threshold, and be one above 50 nanomoles, judging from the Calciferol report in America. Therefore, the changes seen with MRA are too small to induce health effects. So the big question is, can you overcome this well-recognised problem of non-linearity of the associations of D status with outcomes? Well, I've dredged my inexpert brains to think of possibilities. It occurred to me that in doing your genome-wide association studies, you could leave out data from subjects whose 25Ds are along the plateaus for the effect of interest, and just use the steep slope data to calculate genetic variance. And that, of course, might give you a better chance of seeing effects in the study. But then the question is, could you use all of the data set for the Mendelian randomisation analyses, or would you have to use those data sets that you'd used in the GWAS? If that proved to be at all interesting, then of course you could also try looking around known 25D thresholds in the subjects in your large data sets. If that proved to show anything significant, it would be interesting also to consider stratifying the data sets for use in MRA And it might be, therefore, that for other conditions, you might detect new thresholds. These are ill-informed suggestions, and other suggestions are not only welcome, but surely are very necessary. Now, the link of D deficiency to COVID risks is largely ignored because it's blamed on reverse causation. Everybody assuming that if it's reverse causation, vitamin D problems just are irrelevant. But this cannot be right because it reduces 25D, the substrate for all target tissues, and therefore it adds to the supply problem for all target tissues, whether they're immune tissue or bone or whatever, in effect creating a vicious circle. So this dismissal of vitamin D because of reverse causation, now that we know that it's a specific mechanism and not coincidence, may be proved to be very regrettable. So in order to get public health action on this particular problem, which is globally so common, we still need decent trial data. Certainly in Britain there's no good government funding for such studies that I know of. There are 2 useful trials going on that should one should have completed, one's due to complete in July. For prevention, I know of one trial in the UK which is being done right across the country using 3 different doses, and that's due to complete shortly. That was a battle royal to set up because there was no official or formal grant funding, and Martin Yu and colleagues have had to raise funds independently from charities, for example. We need further trials of treatment, particularly with Calciferol, and that's warranted. What's more, the stuff is now, this metabolite is now available. I think it's currently being made from Holland and other places. And the last question about repletion, and Britain will sit here saying, our officials and government no doubt will say, vitamin D can't matter, we've advised 400 units a day for everybody, all through the pandemic, and we've even supplied it to those in care homes, etc. Well, that's fine, and very welcome. But our National Institute for Clinical Excellence points out that deficiency, which is just a blood level under 25 nanomole per litre without any other qualification, for treatment, and this is published in their words, requires a total of 280,000 units in divided doses over the first 10 weeks, including possibly being given at 4,000 units a day. And this is a known safe intake at the population level globally, and that then such people should take 800 units a day for life. Insufficiency, in their view, also requires 800 units a day. Since populations can't be screened, and clearly 400 units a day will not deal with the high risk of deficiency groups, because it would take 2 years to get 280,000 units. It would be better to let everybody with that pandemic, particularly in the winter, which we've done it last year, autumn in my view, should take all of that, should take 4,000 units for 4 weeks, and so they have renal stones or other sarcoidosis, other risks of vitamin D hypersensitivity, followed by, I would suggest, 2,000 units and 800 units a day after that. Low risk groups probably also need 800 to 1,000 units a day at the moment, because we've had a year or more of lockdown. And 400 units a day cannot be expected to do the job, not even for musculoskeletal health. So I would be happy to provide references or further details if anyone needs them. That's my email, which is also available on PubMed. And I would acknowledge all those I've worked with, learnt from, all those who added to knowledge about vitamin D beyond bone, which is as far as most people seem to think when you mention the word vitamin D, and say how grateful I am that this knowledge has been developed, and that I'm sure that eventually it will be made good use of, although it's proving a battle to get people to take this problem on board. Thank you.